Hemorrhoids, also called as piles. Hemorrhoids are dilated plexus of superior hemorrhoidal vein in relation to the anal canal. Classification or etiology of hemorrhoids. The first one is primary or idiopathic hemorrhoids. Under this, we have in standing posture, upright posture and absence of valve in the portal system precipitates the development of hemorrhoids. The second one is hemorrhoidal veins and their branches get compressed due to contractions caused by rectal musculature during the act of defecation. The third one is genetic factors, for example, absence of valves or congenital weakness of the vessel wall. The fourth one is diet. Diet deficient in fibers, which prolong the gut transit, results in constipation and small hard pellet like stools. These hard stools compress the veins and result in hemorrhoids. The second classification is secondary hemorrhoids. Under this, we have carcinoma of the rectum, can produce back pressure and can manifest as piles. Portal hypertension, it is uncommon. Thirdly, also seen in case of pregnancy due to compression on the superior rectal veins or due to progesterone which relaxes the smooth muscles in the wall of veins and can cause hemorrhoids. The third classification depends upon the location of hemorrhoids. We have internal hemorrhoids which are covered with mucous membrane above the dental line. External hemorrhoids covered with skin at the anal verge. Interno-external hemorrhoids. Location of hemorrhoids. Hemorrhoids are classically situated in the 3 o'clock, 7 o'clock and the 11 o'clock positions, that is, the left lateral, the right posterior and the right anterior. The superior hemorrhoidal artery or the vein gives 2 branches on the right side and 1 branch on the left side. Therefore, piles are 2 on the right and 1 on the left. Clinical features of hemorrhoids. Painless bleeding occurs. Fresh bleeding occurs after defecation, which is also called as splash in the pen. This causes chronic anemia. In grade 1 hemorrhoids, the hemorrhoids bleed. Minor trauma can precipitate bleeding since capillaries of the lamina propria are only protected by single layer of epithelium. After defecation, it returns back or can be digitally replaced. In most of the cases, patients complain of constipation, discharge of mucus and soiling of the perianal skin occurs. Grades of hemorrhoids. Grade 1, never prolapses, symptoms bleeding per rectum. Grade 2, prolapse on defecation, spontaneous reduction, symptoms something coming down and going back. Grade 3, prolapse on defecation requires manual reduction. Symptom, something coming down, bleeding, mucus discharge and pruritus. Grade 4, permanent prolapse. Symptoms, acute pain and throbbing discomfort. Investigations for hemorrhoids. Per rectal examination to rule out carcinoma of the rectum. Proctoscopy, as the obturator is removed, piles prolapse into the lumen of the proctoscope as cherry red masses. Sigmoidoscopy to rule out proximal cancer. Complications of hemorrhoids. Chronic anemia due to portal hypertension. Prolapse outside results in venous congestion and edema followed by strangulation. This can be treated by foot and elevation of the bed. Metronidazole 400 mg 3 times a day for 5 days. Saline dressing to reduce edema. Local lignocaine jelly application. Other complications include ulceration and thrombosis. Treatment of hemorrhoids. Non-operative management includes fiber. So F for fiber supplementation, I for increased fluid intake, B for bulk purgative and laxatives, R reading in toilet to be discouraged and discontinued, E encouraged to lose weight. Then we have injections of sclerosant. 5% phenol in almond oil is injected into the submucosa above the dental line. The injection is perivascular. Then we have Behrens band application. Bands are applied at the neck of the hemorrhoids, causing necrosis, and the piles get fibrosed. One or two can be banded at a time. This is indicated in grade 2 and grade 3 hemorrhoids. Operative management includes hemorrhoidectomy. Excision of pile masses up to the base is indicated in grade 2 and grade 3 hemorrhoids. It can be done by 3 methods: open method, close method, and by stapler. In the open method, stretch the sphincter, identify the pile masses, dissect up to the base, transfixation ligature with non-absorbable silk, excision of piles, trimming of wound. Hemostasis is obtained, wound packed with roller gauze, tube drainage to let the oozing blood escape out. Closed method. The basic steps are the same. Cut the mucosa and the skin edges are sutured with absorbable catgut sutures. Post-operative management, strong analgesics, antibiotics, bulk purgatives, sitz bath using warm saline or KMNO4 solution. Post-operative complications in closed method includes urine retention, reactionary hemorrhage, secondary hemorrhage, anal stenosis, and wound infection. Stapler hemorrhoidopexy. This is a non-excisional procedure. It is also called as PPH, that is, procedure for prolapse and hemorrhoids. After reduction, a proline purse string suture is applied circumferentially. This is possible by the circular anal dilator, which is the CAD. By maintaining traction in the tails of the suture, the stapler is fully closed and fixed. Slowly, the stapler is opened and withdrawn. 2 rows of staples and 28 staples are present. Advantages include less operative time, less bleeding, less post-operative pain, less post-operative hospital stay, early return to normal activities, and no major long-term complications. Disadvantages include high cost of instrumentation and it needs special training. A point to remember: look at the donut. If it is complete, then nothing to worry.